class. This is Professor Shokunbi taking you on manual therapy and manipulative therapy. Today, basically, what we want to do is an introduction. We'll be having an introduction into some terms that we use in manual therapy, and this will usher us into learning about the techniques that we use for the upper extremities and the spine. All right. Our learning objectives will be that at the end of this class, you should be able to know the difference between mobilization and manipulation. You should be able to know what it means, of course, and know the difference between them. Know something about kinematics, accessory movement, joint place, scapulohumeral movement, things like that. You should be able to know shape of the joints in the light of convex concave surface rules, and should be able to describe the effect of joint mobilization and manipulation. So let's go straight away to mobilization. All right, what's mobilization? What's manipulation? I have once had a very senior colleague asking me, but it's not in manual therapy, so I don't blame him. So asking me whether there's a difference between mobilization and manipulation. I told him that straight away, looking at the two techniques are carried out by an external force, so it's like a passive movement, but in the course of carrying them out, they don't mean exactly the same thing. How else do I mean? When mobilization is done with varying speed and varying amplitude, but the speed and the amplitude of manipulation is very specific. If you look at the diagram above, the diagram on slide number 3, if you look at the top diagram, you see the therapist there using his proximal arm with the hand on the head of humerus to push downwardly on the head of humerus. He can decide to do that at varying speed, at high speed, low speed. That's mobilization. If you look at the ladies on the bottom diagram on the left hand side, she has one of her proximal arm going through the armpit and the elbow of the patient, and the distal hand on the gluteal region. So what she's going to do is to push the proximal part of the body of the patient towards the bed with her own proximal hand, and she'll use her distal hand to move the buttocks of the patient alternately towards her own body. And she can continue this rhythmical movement at varying speed that she likes. That will be mobilization, as long as the speed and the amplitude is controllable. It's under the control of the patient, it's under the control of the therapist. The same thing applies to the third diagram. One hand on top of the other, placed below the spinous process on the facet joint with the pisiform resting on the lumbus below the spinous process or facet joint. Posterior anterior thrust can be delivered rhythmically, at varying speed and varying depth. That is mobilization. But it becomes manipulation when, for instance, that therapist we discussed about, I'm on slide number 4 now use the proximal hand to distract or push away the upper part of the body of the patient towards the bed, simultaneously as she's pushing the buttocks of the patient to herself. The two movements are taking place at the same time, and it got to a point there's no movement again. So we said the joint is locked, or we said he has taken off the slab. If at that point of joint locking, she now delivered high speed and low amplitude movement, then that's a thrust, and we said she has manipulated the spine. So manipulation is actually carried out at high velocity and low amplitude. Now the velocity is so fast that it's beyond patient control, unlike immobilization where the velocity is so low that both the patient and the therapist are in control of it. Is that clear? We use them for different purposes that you are going to discover later. Let's go to slide number 5, where we talk about direct and indirect technique. When do we say a technique is direct in manual therapy? We said a technique is direct when movement is carried out in the movement of restrictive barrier. Maybe you have a patient that comes to your clinic and is not able to do extension of the knee because the hamstring is tight. He cannot extend the knee because the tight hamstring will hold him back. Anytime he tries to do that, he experiences more pain. And the therapist come, and the only thing the therapist could do is to move the leg in the direction that is causing the patient pain. That is knee extension. And that's the direction we call restrictive barrier. So that's when we say the technique is direct. So the technique is direct when the therapist moves the body in the direction of restrictive barrier, movement barrier, discomfort in the direction of pain. And this direct technique is mostly used in manual therapy to treat tight soft tissues, muscles, contractile elements, soft tissues, connective tissues in the body. Whenever they are tight, we use direct techniques. We find a way that causes the patient pain. We move the joint to sustain it. The neurophysiological mechanism will set in place and the muscle will relax, or the contractile structure or the connective tissue will stretch enough and get adapted to that stretch condition. Then we have indirect technique. When do we say the technique is indirect? If you look at the lower diagram there, it is possible that that man there has developed a neck problem and is finding it difficult to turn his neck to the right. So the therapist decides to treat him by turning his neck to the left, away from restrictive barrier. That is what we call indirect technique. Do you understand? Now, what could make the patient develop problem that he will not be able to turn his neck to the right? It could be due to osteophyte forming on the right hand side. It could be due to disc herniation going to the right hand side. It could be due to ligaments, hypertrophy blocking the right hand side, a lot of things. Now, this thing present on the right hand side, preventing movement and altering the normal anatomical movements of the joint, are what we call impingement or internal derangement in manual therapy. So basically, the way to treat them is to create a gap for them to be reabsorbed back into the body. And that's exactly what the therapist will do by applying traction and moving the neck in the opposite to restrictive barrier. If you decide to move the neck to the right, it will be causing more compression on those impingements, and that will cause more pain for the patient. Okay, then move to slide number 6, where we discuss kinematics. Now, kinematics is another term we have to introduce. It's just an aspect of biomechanics that deals with movement without consideration for the force that is producing the movement. You know, force and movement are like brothers and sisters in biomechanics. A force is needed for movement to take place. A force is used to change the direction of movement. A force is used to stop the movement. So, when we talk about the movement alone without consideration for the force, then we said we are discussing kinematics. Is that clear? So, and this movement take place in different parts of our body, and that's what we want to quickly look at. The two kinematics we have in the body are osteokinematics and arthrokinematics. All right. Now, what is osteokinematics? When you look at the word itself, the first part of the word, osteo, is bone. So it means movement of bones away from bones, or movement of bone towards bones. That's osteokinematics. So when I ask you to move your arm away from your body, that's what we call abduction in anatomy. That is osteokinematics, because then humerus is moving away from glenoid cavity. When I ask you to move your arm straight in front of your body, that is bone moving away from bone, because humerus is moving away from glenoid cavity. So all the range of motion that we talk about in physiotherapy and related medical sciences, like flexion, extension. If the arm moves backward, is extension. If it moves forward, is flexion. If it moves sideways, away from the body's abduction. If it moves close to the body's adduction. If it rotates away from the body, that's external rotation. If it rotates towards the body, that's internal rotation. All these movements are osteokinematics. When you take out your goniometer to measure movement, you are measuring osteokinematics. All right? Other things that are related to osteokinematics are axis of movement and plane of movement. There's no how you describe flexion, extension. The description of flexion, extension, abduction, adduction, internal, external rotation is not complete in kinesiology unless you mention the axis and the plane of movement. So the first assignment I'll give you is to read about the axis and plane of movement for all the joints in our body before our next class. And that assignment is what you have on slide number 9 to 11. I think on slide number 9, you're going to see the blue arrows. Blue arrow describe the movement. So I want you to tell me the movement. When the arms is moved away from the body, that's abduction. What is the plane of movement? What's the axis of movement? Okay. You name the movement and you know the axis. That is also what you have. You name the movement in slide number 9. Slide number 9 is to slide number 9. I'll call you. I'm in the class. Slide number 9 is to name the movement, name the plane, and name the axis of the movement. You have that from slide number 8, slide number 9, and slide number 10. Okay. Now, still talking about osteokinematics, movement of bone away from bone in our body could be limited by a lot of factors. For example, the shape of the joint. If the shape is distorted by inflammation or infection, the movement isn't going to take place. If the joint capsule is fibrosed, if it's inflamed, it's not going to allow the movement to take place easily. If the ligament that hold the bones together is weak, it will affect the movement, and the muscles are the contractile element that bring about the movement. So if the muscles are weak, all right, the movement isn't going to take place. So these are factors that could limit osteokinematics, or we could say factors that could limit range of motion. Now we have to talk about arthrokinematics. Like the word arthrokinematic implies, arthro suggests joints. Kinematics is movements. So if you have a look at this diagram of arthrokinematics, where we discuss abduction, as the arm is elevated and lifted up away from the body, you also see the head of humerus rolling inside the joint. So that implies that it's not just the movement outside of the joint alone that take place. When we move different parts of the bone, there is also component movement that take place inside the joint. And that's what we call arthrokinematics. That's what I'm in a class, so you'll have to wait or come back. So that's what we call arthrokinematics. So the arthrokinematics, compared to osteokinematics, they are 5 in number. They are not large movement like osteokinematics. They are small movements. They are not under voluntary control. That's why we call them accessory movements, and they are not large movements. So these are points of differences between arthrokinematic and osteokinematic. They are small movements, they take place within the joint, and they are not under voluntary control. For that reason, we call them accessory movements, isn't it? And like I told you, there are just 5 of them. Rolling, sliding, spinning, compression, and distraction. These are the 5 of them. Coming. These are the 5 of them. So we're going to look at each of them one after the other and discuss them. Let's look at rolling, for example. The best way you can understand rolling is to imagine rolling the tire of a vehicle on the floor. Imagine you want to roll the tire of a vehicle on the floor. For the tire, while the tire is moving, a point on the tire will make a contact with a point on the floor, isn't it? For the tire to keep moving, another new point on the tire will make another contact with a new point on the floor, and that will have to continue. And that is why rolling is described as a movement that takes place when a new point on the moving surface, that is the tire, is making contact with a new point on the stable surface as the movement continues. And that's exactly what you have in that diagram. If you look at this diagram, in the glenohumeral joint, during abduction, this part of the head of humerus make contact with this part of glenoid cavity. Another part of the head of humerus will have to make contact. Another part will have to make contact for that rolling to be completed. The stable bone here is the glenoid cavity. The moving bone here is the head of humerus. Do you understand? So rolling is basically described as a movement in which new part on the moving surface is making contact with the new part on the stable surface. And take it from me, All the joints in the body have some element of rolling when they are moving, whether in joints or ball or socket joints. It might be small, it might be big. Some joint naturally exhibit large rolling and small gliding. Some do big gliding and small rolling, but they all have a component rolling and gliding. You understand? Then we look at the second type of arthrokinematic, which is called sliding or gliding. How do we describe sliding or gliding? The best illustration to that would be to look at a man skating on an icy floor. All right, can you see the diagram of the man skating on an icy floor there? Now, the same surface of the shoe of the man will have to move from old point to new point, another new point, moving forward for the movement to take place. So we say sliding or gliding take place when the same surface of the moving bone make new contacts with new points on the stable bone. The same point on the moving bone is making contact with new points on the stable surface. That is gliding. And that's exactly what you have with this woman in the diagram. Can you see that woman in the diagram? So as she's pushing through the glenoid cavity, she's pushing on the head of humerus, isn't she? In a downward manner. So the whole of the head of humerus will be making progressive contact with different points on glenoid cavity. And just like I told you, gliding and sliding take place in all the joints in the body, but to a varying degree. So that means the combined rolling and gliding that we have in most of the joints. So how do we know the joint that does more rolling than gliding? And how do we know the joint that does more gliding than rolling? There is a rule, as a rule of congruency. The more congruent the joints, the more rolling. The more congruent the joint, the more gliding. The more incongruent, the more rolling. Look at the knee joint, for example. The femoral condyle is shaped like convex, and tibial condyle is concave. They are perfect match, and they're just like feet. They are congruent. So gliding will be the large movement there, and rolling could be just the very small component. But when you look at glenohumeral joints, you see the head of humerus is perfectly circle, and glenoid cavity is just like half or 1/3 part of the head of humerus and is concave. So they are incongruent. So in such a joint, more rolling will take place. So the more congruent, the more gliding; the more incongruent, the more rolling. Is that clear? Then move to the third arthrokinematic movement, which is spinning. Now, spinning occurs, if you just look at this diagram on my slide, you're going to see this spinning. You see two bones there, right? The top bone is the stable bone. It's not moving. The lower bone is the moving bone, and it's rotating about the longitudinal axis of the stable bone, and that defines spinning. Spinning takes place when the lower bone rotates about the longitudinal axis of the stable bone. Do you understand? And that's what we have in pronation and supination. What do we have in pronation and supination? There's a longitudinal axis down the humerus, and the head of radius rotates clockwise about that longitudinal axis to make pronation, and it rotates anti-clockwise about that longitudinal axis to make supination. All right? Then the last two of the arthrokinematics are compression and distraction. Now, before I teach you compression and distraction, I just want us to do a little mental exercise. I want us to do a little mental exercise. Now, just imagine yourself seated on a chair and think about the joint space in the knee joint. Okay? You've done that. Now, stand up. Imagine yourself standing up and think about the joint space in your knee joint. What happened to the joint space in each of those two positions? What happened to the contact between the bone in each of those positions? You are going to agree with me that when you are seated, the joint space is increased and the bone are separated from each other. That's what we call distraction. You're going to agree with me that when you stand up, the joint space reduces and the bone comes in contact with one another. That's what we call compression. Do you understand? So when Movement take place in the joint in such a way that joint space is now enlarged or increased. We call it distraction. And when movement take place in such a way that the joint space is reduced, we call it compression. It happens during arthrokinematics. And you see the diagram above. A therapist is trying to do mobilization of the metacarpophalangeal joints. Now, metacarpophalangeal joint, the chief anatomical movement that take place in metacarpophalangeal joints is flexion and extension, isn't it? It's just flexion and extension. Now, you will see the therapist stabilizing the metacarpal with his own proximal hand, and he's using this hand to hold the proximal phalanx. For extension to take place, don't forget that when I said when you stand up, your knee is in extension, and that's when the joint is compressed. Compression is useful to rehabilitate extension. And when you sit down, that's when the bone are distracted, the joint space is increased. So distraction is useful to promote flexion. So for the therapist to rehabilitate flexion here, it will apply traction on the proximal phalanx to increase the joint space and then push into flexion. And for him to achieve extension, it will move the bone upward and apply a little overpressure to cause compression. All right? So that's how we use this movement of compression and distraction further in manual therapy. We also apply distraction force whenever we're doing manual therapy for the radiculopathy in the lumbar spine and the cervical spine. Is that clear? Now, another movement yet not really arthrokinematics, but it's also an involuntary movement that takes place in our body is what we're going to discuss next. And that is called scapulothoracic. The movement takes place between the scapulothoracic joint and glenohumeral joint. And the movement is called scapulohumeral rhythm. Now, this scapulohumeral rhythm is, let me say, is a compression or synchronization of movements between glenohumeral joints and scapulothoracic joints. All right? Anytime the arm is about to be elevated, either through abduction, the arm will have to go from 0 to 180 degree. And for 180 degree abduction to take place, as you can see in that diagram, the glenoid cavity has to point vertically upward toward the sky. That will not be possible if scapula refuses to move. So the scapula necessarily has to abduct when elevation is taking place. So that's what brings about the cooperation of movements between scapulothoracic joints and glenohumeral joints called scapulohumeral rhythm. So what happens ordinarily is that at the onset of 0 to 30 degree abduction, the scapula is getting ready to move. We said the scapula is setting. Then from that time onward, every 2 degree movement of the humerus will produce 1 degree movement of the scapula. Yes? So what we have in essence is that when humerus has made 120 degree movement, the scapula has made 90 degree movement. So the ratio is 2 to 1. And this movement is so important that it takes place so that full elevation of the arm can take place. So if you are managing a patient and you've done all you could to the glenohumeral joints and you are not getting full elevation, it might be a time to visit the scapulothoracic joints and do a very good mobilization, and also do us some exercises to restore the normal scapulohumeral rhythm, because that cooperation of movement is very necessary for full elevation of the arm to take place. Now I go to slide number 21, where I'll be talking about the joint play. I've talked about gliding, rolling, spinning, compression, and distraction. And we said they are arthrokinematics because they take place in the joints. Now, every bone in a joint is surrounded by a capsule. Do you understand? It's surrounded by a capsule. So if the capsule is not stretchy or accommodating enough for those movements to take place, they are not going to take place in the first place. Do you understand? So any movement that takes place as a result of laxity in the joint capsule is called a joint play. If the capsule is so tight, it's not lax enough to allow those movements to take place, then there will be no rolling, there will be no gliding, there will be no spinning, there will be no compression, there will be no distraction. So it is all right to say that rolling, gliding, spinning, compression, distraction, they are different forms of joint play. Now, we cannot call scapulohumeral rhythm a joint play because capsule is not involved in that movement. We cannot even call it arthrokinematics because scapulothoracic joint is not a true joint in the body. I hope you understand me. Now, we're going to talk about joint shape as we are wrapping up. Now, you've been taught in your IA levels or your physics that when an object curves inward, we say that's concave. When it curves outward, we say that's convex. And that's also the way we have them in different joints in our body, isn't it? If you look at the knee joint, for example, the femoral condyle is curved outward, that's convex. And tibial condyle is curved inward, that's convex, concave, isn't it? Then the same thing applies to hip joints and shoulder joints. So when you have a joint and one end of it is convex, the other one is concave, you call it an ovoid shaped joint, all right? But it's also possible to have in some joints in some part of the body whereby the top bone will not be totally convex. Part of it will be convex, the other part will be concave. And the lower bone will not be totally concave. Part of it will be concave, the rest part will be convex. And where the upper bone is convex, the lower bone is concave. Where the lower bone is concave, the upper bone is convex. So they can fit perfectly into one another. Such joint is called a saddle joint. We need to understand the shape of the joint so that we can make out, we'll be able to predict almost correctly what will happen after mobilization or manipulation in a joint. The shape of the joint determines the result that we get. Now go to slide number 25. Talking about the result that we get, there is a manual therapist, a manipulative therapist called Kattenborn, that came up with some set of rules that enable us to be able to decide and determine what we get during manipulation. All right, that tell us what we're able to get during manipulation. I'm in a class.
Hello?
That enable us to get, that tell us what we're able to get during manipulation. Now, if you look at the diagram that I projected, you see there are two joints. Look at the joints above. There is a bone. There is a bone on the left hand side, which is concave, and there's another bone on the right hand side, which is what? Which is convex. Now, you know, we talk about moving bone, stable surface, all right, and moving surface. If a therapist decides to come and mobilize this joint and decide to move the convex bone, leaving the concave alone, like pushing the convex down, can you see the light blue arrow? That's pushing the convex bone downwardly for 2 to 3 minutes. After he finishes all his effort, the patient is going to notice that he's able to move that convex bone in an upward direction. He's able to move the joint in an upward direction, whereas the therapist is pushing on the convex bone downwardly. So that's opposite to what the therapist is saying. So Kattenborn came up with a rule to say that when a convex bone is moved on a concave bone, the movement, the gliding, that's what the therapist is doing, is called the gliding. The gliding and the movement gain will be in the opposite direction. The gliding is downward, the movement gain is upward. But look at the situation below. Where you have a convex bone not moving, a concave bone is the one moving. Can you see the light blue arrow pointing on the concave bone? It's pushing upward, isn't it? And by the time the therapist finish, patient will also be able to move upward. Oh, so he said when you move concave bone on convex, both the gliding of the therapist and the movement gain will be in the same direction. And that's what is called concave rule. When you move convex, you get convex rule. When you move concave bone, you get concave rule. Okay. And that is what Kattenborn called convex rule and concave rule. You could also call convex rule concave convex concave rule, and you could also call concave rule concave convex rule. Okay. We're going to round up. Oh, let's look at the illustration of that on slide number 27. Can you quickly look at slide number 27? Look at the therapist on the left-hand side. It's pushing on the head of humerus posteriorly. And you know the head of humerus is convex, isn't it? And you know posteriorly directed movements on glumeral joints should cause extension, isn't it? But because it's convex rule, and opposite is always what is gained when you move the convex board, after all the effort of the therapist, the patient is going to gain more flexion instead of extension. That's the opposite. It's going to gain more movement in the upward direction, whereas the therapist is pushing in downward direction. But if you look at the diagram on the right hand side, you see the therapist is pushing the knee into flexion and is pushing on tibia. And tibia is concave, so it's moving concave, not convex. So the more he pushed on the concave bone, and at the end of his effort, patient is still going to gain flexion. So that is to say that when the concave is moved on convex, both the movement and the gliding will take place in the same direction. And we're going to wrap up this morning with the effects of manual therapy. And we can sum up all the effects into neurophysiological, mechanical, and nutritional. So let's have a look. Let's have a look at the mechanical effect. When we talk about mechanical effect of manual therapy, we're talking about effect that is related to movements, all right? Whenever there is hypomobility, reduced movement in the joint, we can go there, do our direct technique, indirect technique, do our oscillation, movement will increase. So generally, mobilization manipulation is used to deal with hypomobility. We do not apply mobilization manipulation when there is hypermobility. No. We only, if we notice hypermobility in a joint, we will not apply mobilization. We will check the adjacent joint, whether the adjacent joint is hypomobile, and we find that that is hypomobile, we will not apply manual therapy. But we will not apply manual therapy on hypermobile joints. Instead, we do stabilization on hypermobile joints. Then it's also useful to maintain extensibility and tensile strength of articular structure. We've talked about direct technique. When it is less extensible, when it's contractile, when it is tightened, we can stretch it with direct technique. So all this comes under the mechanical effect of manual therapy. Now we'll talk about neurophysiological effect. For the neurophysiological, we're talking about when manual therapy is carried out, the movement is carried out, the receptors sensitive to movement in the joints, in the muscle, in the tendon, called mechanoreceptors, they will start firing impulses to the central nervous system, and these impulses could cause pain gate closing mechanism. It could cause pain gate closing mechanism at the level of spinal cord. It will cause relief of endogenous opiates from the brainstem, which can mitigate, modulate, or stop the pain altogether. That's neurophysiological effect. And you will not forget that whenever there is pain in any part of the body, the muscle, in most cases, the muscle very close to that area of the body tends to contract. And that's what we call spasm, in order to protect further injury to that part of the body. So when we've done manual therapy to mitigate the pain, we are also relieving muscle spasm. So all these are neurophysiological effects of manual therapy. Then we come to nutritional effects. Now, particularly in synovial joints, peripheral joints, and facet joints in the body, they get most of their nutrients from the synovial fluid. But this fluid, this nutrient does not just easily leave the fluid and go into the bone. It takes place by the process of diffusion. So the more movement we apply in the joint, the more diffusion will easily take place that will lead to the movement of the nutrient from the fluid into the bone. So this is where we're going to stop today. Read about joint axis, plane of movement, description of different joints, know about abduction, adduction, flexion, extension, different movements, because these are going to be relevant points for us as we move into different techniques of manipulation. Thank you for your attendance now. I'll see you some other time as scheduled. Thank you and enjoy the rest of your time. Bye bye.